without further ado, we are ready to get started with a longtime supporter of this conference, Dr. Timothy Fong, who is co-director of the UCLA Gambling Studies Program, a professor of psychiatry at UCLA, and board certified in adult and addiction psychiatry. And he will be giving us the presentation, Principles of Prevention and Treatment of Gambling Disorder. Please join me in welcoming Dr. Fong.
How you doing this morning? All right, I got some new material worked on the plane here, so hopefully these things will entertain you and then we're going to move them on. Again, thank you for that wonderful introduction. Again, my name is Dr. Timothy Fong. I've been doing work in gambling studies since 1998, and I was thinking about a couple of things on the plane over here. Is that come to Vegas probably about 4 times a year since 1998. So that means I'm probably on my 100th trip or something like that to Vegas. So it really does feel like home, particularly the Suncoast Casino here. We were here in March 2023 when we did the last conference, and so I love this place because nothing really changes. So it's really wonderful. And also for a talk like this, and again, show of hands, how many of you, this is your very first gambling conference? Isn't that amazing? Isn't that amazing? So I do a lot of these kind of gambling disorder 101 talks, and I always talk about how critically important it is, because this is fundamental stuff. I opened up my hotel window this morning, and I can see the TPC golf course, and I'm watching these guys tee off. 3 of them slice it. 2 of them I can tell just by their stance, they're going to push it to the right? Fundamentals. Basic fundamentals. Another guy, he just didn't finish his swing. Pushes it to the right. So, really, I think the goal today is really go over fundamentals, things that I've learned in 25 years, things that I'm still learning, and things I think we all can benefit as a refresher to say we should be doing this as part of our daily experience. How's that sound? So I have about 45, 50 minutes material and plenty of time for conversation thereafter. I just want to start with the most recent case I saw, just to give you a sense of what I'm seeing, what we're all seeing, and how I do it. You know, again, 90% of the work that we do now is telehealth and care. A lot of providers, right? Prevention work, some of it's telehealth there as well, but there's still much less in-person. So I think we really think about what that looks like. So this is a 22-year-old man who was referred to see me by his mom. So we start with that, number one. How do we get him to actually call me first to make an appointment? He didn't really want to come in, right? His mom did. But his mom was very concerned. She's like, I'm worried about my son gambling. And she's 22. You know, our son's 18. I'm not really doing anything for him anymore. Am I somehow the Gen X parent and not a helicopter parent? But that's a different story. Number 2, this is a telehealth appointment. That means I only see him from the shoulder up. So 60 minutes, and this is going to be the way we're going to do it a long time. So he tells me, 2020, I started gambling online a couple years ago. I played poker in high school with friends. I loved sports. It was interesting. And during the pandemic, I saw this as a way to make money, not to have to get a job. My mom, and the mom is a bit of a helicopter parent, says, I don't want you working during the pandemic. I don't want you doing anything for essential services. I want you to stay safe. So he said, well, online gambling, maybe I'll make $50 to $100 a week, tax-free, right? I can buy stuff from DoorDash and things like that. It's really all he could do during COVID. That's 2020. 2020, 2022, on and off. And then, as the pandemic proceeds, he would estimate he'd spend about $500 to $1,000 per year on this gambling behavior. We use that language. Is that a lot? How much did he spend on movies? How much did he spend on DoorDash and Uber Eats? Way past that. So we're not talking about a huge amount of financial distress. But there was one 3-month period toward the end of his college experience where the symptoms of gambling disorder started to show up. Preoccupation that lasted all day, grades and neglecting going to class, but not so firm that his mom was aware of it, or he lost friends, or he did any sort of criminal activity. But he was doing a lot of this on the unregulated gambling website. So no brick and mortar experience, right? This is really unusual for a lot of us, is that how many of us have patients who've never set foot inside a casino, ever? And now we're working with them exclusively in the online space, not only with them, but that's their experience in the addiction space there as well. So, pandemic recedes. He goes off to law school, proceeding nicely in life. And over the last 12 months, this is what happened. Law school gets difficult. He has a 35-minute commute to go there. He doesn't have a lot of community with his law school classmates. And then right around Christmas time, kind of burnt out a little bit, kind of a little bit bored. And he says he gets caught up in the hype of sports betting that he sees every day driving to classes. The billboards, the radios, ESPN, apps and social media, constantly. And he realizes, I never closed my unregulated sports betting account. So he goes back and reopens and starts gambling again. This time, this is the second episode now, it's a little bit different, where in 3 or 4 months' time, instead of just $1,000, he's now up to $5,000 in gambling expenditures. He's gambling more frequently, daily, several times per day. He's chasing losses, more again preoccupied that resurface again from a couple years ago. 5,000. And again, when you asked him, well, why was it different this time? And he said, because the gambling experience was different. I had constantly steady stream of bets that were being offered to me. It was on my phone. I could do it while driving to class. That wasn't available a few years ago. His mom discovered spending, calls him out, says, hey, I'm concerned about this. This is a lot of money you're spending. She did have the ability to look at the credit card. They were in a shared account. And she's like, I need you to go get help and treatment. And immediately she's like, I need you to go to a gambling residential program. Now that's a big step, right? So during this 1 hour, we talk 45 minutes, and the final assessment is 2 things. One, yes, he has gambling disorder, moderate severity, and then number 2, he had a mood disorder that previously was not diagnosed. And right around December 2023, what he experienced as blondness or moral injury, in fact, was mild depressive symptoms. The treatment, this is right away. This is minute 50 to 60 in this 1 hour block I have. It's really only 10 minutes where I'm going over the treatment plan. I say, after this first visit, here are the things I'd like you to do. Number 1, I'd like you to go to a smart recovery meeting. He's absolutely dead set on going to GA. I said, I'm not going to change your mind about GA right now, but you do need community support. I really want you to go to a smart recovery meeting. He's willing to do that. Number 2, we talked about medications for his mood, but he wasn't ready to do that. Number 3, we talked about the importance of setting up weekly psychotherapy with one of our state therapists. But I think the key there is I described to him what to expect from therapy. Many times when we start therapy with patients, we don't take a couple minutes to say, this is what therapy is going to do. These are the potential risks. These are the potential benefits. This is the type of therapy I'm going to provide to you. Actually declaring it. And I think that's a fundamental thing we've gotten away from. Really describing to folks, this is how our plan is to get you better together, not me telling you what to do. And then I gave him 3 homework assignments. Number 1, I said, part of the issue with your depression is that you lacked other routes and arenas for where your dopamine needs to be parked and expressed. So in December 2023, it was only sports betting. Let's look at other things. It turns out he used to be an avid basketball player, and he stopped that during law school. He used to be an avid pickleball player, and he stopped that during law school. So immediately we identified 2 things. The third thing we identified is you're spending almost 10 hours a week commuting, and he grew up in a culture of no commute during the pandemic. We hadn't learned to adjust his timing and his lifestyle to that commute. So those are the things that we identified. We talked about very simply behavioral task number 1, deleting the app right then and there. So in the actual session, toward the end, I said, I want you to show me your phone, and I want you to show me that you're deleting the app and putting it into the trash. So again, now with the power of telehealth, you do that. That's where you can do it in person. And again, is it a strange boundary violation to look into his personal effects and actually see that? But for him, it was therapeutic for him to show to me that he was actually moving the app into the trash. And number 3, I know you have a session here with Brian and other folks on podcasts. Where are the podcast folks? Where are our podcast folks? I actually said to him, I want you to go on the All In podcast. And there are well over 100-something episodes there. I want you to drift around and listen to the ones that make sense to you. Listen to the ones that call you. But that's session 1. That's in 10 minutes of the end. That's kind of how we're doing treatment and how treatment can be done effectively. Let's go all the way back to the very beginning, the fundamentals. We go back to defining gambling. Gambling, again, as placing something of value, usually money, but could also be time, on a bet of uncertain outcome in hopes of winning larger reward. For traditional forms of gambling, of course, we game to chance. We have to remember there's so many other newer ones, including social casinos where there is no money that you earn other than virtual coins, crypto trading, financial trading, all those various things. They are all forms of gambling. The trends that obviously we're all seeing in America and here in Vegas, I'm sure. Number one, traditional gambling activities. Last year we talked about sports betting. This year we're still talking about it. It's changed so much even from a year ago when we were here, 38 plus states, mobile options. But the one thing I would highlight for folks is recognizing the type of bets and wagers that are available in sports betting is so different than it was just a few years ago. So right now we know that about 45% of the bets that are being placed are same-game parlays, where it's small bets to win much larger jackpots, very different than betting straight win or loss sort of things. Brick-and-mortar casinos still continue to thrive. And again, isn't it interesting now, did the Mirage close already? Is that happening? Or is that July? So it was very interesting when I saw that online. I got nostalgic. That was one of the very first gambling conferences I went to was at the Mirage, I think right around 1999. Met a lot of friends and colleagues there, and it's obviously an important part of the history of Vegas. So, but it's still changing. We mentioned again the gaming lines and the gambling lines. So again, in our state of California treatment program, we treat men and women with video game addiction in our state gambling treatment program. So even if they don't spend any money, we're still viewing it because it's so close together. And of course, in the video game world, we see still a proliferation of a lot of loot boxes where people will spend real money in order to obtain something that's inside that box. So absolutely, we pay for that and we support that. We also support, again, folks who come into treatment struggling with financial trading issues. Again, Crypto.com, Webull, Robinhood, Bitcoin, things like that. What's unique, though, is that many of those men and women will say, I do not have a gambling problem. I just lost a lot of money in the stock market. Or I lost a lot of money in the options. I had one guy who very clearly said, I have a can't-lose system of trading. I said, sir, with all due respect, you've lost $1.5 billion. Explain that. He said, I lost it because my wife interfered with my system. So it's really tragic. And unfortunately, the other thing, when I put on this chart, it was all trading 7-day options. Very high risk, very, very, very difficult. And on the chart, I put gambling before. Now at UCLA, and I don't know if it's true here in Nevada, if you're a patient, you can see your chart. You can see notes of what your doctor is writing. You can see the problem list that your doctor says you have. So I put gambling disorder on there, and immediately the next session, he's like, very upset with you, Dr. Fong. I do not have a gambling addiction. Told you that. And you put there in my medical record, I want you to erase it. So it was an interesting area, and I think that's a new area for us in that area of electronic records and telehealth. If you do open notes, it's super important to discuss what that diagnosis is. Actually saying very clearly, based on my time with you, this is very clear to me the diagnosis I'm using and I'm going to put in the chart is gambling disorder. I didn't do that with him. I did that after the fact. And it was actually a case where he chose not to come back. He was very upset. It was very stigmatizing. He thought it was wrong. And I said to him, well, what should I write instead? He said, I don't know, just don't put that in. I could have wrote mood disorder. I could have wrote, depression. But that would be, again, minimizing what he had done. That would be minimizing the condition of gambling. New data that we have, of course, our state of California data, which is now 17 years old, we still hold that up, 1.3% meeting criteria for gambling disorder within the last year. But more recently, I was just in Illinois, and they told us about this. Yeah, get a chance, look at that 2021 prevalence survey that Illinois conducted as they were opening up more and more brick-and-mortar casinos and sports betting. They found a 3.8% prevalence rate of Illinoisans within the last 12 months. So again, we see these numbers fluctuate, change over the last 20, 30 years, all the way from as low as 0.5%, up 4%. Oklahoma, they had one recently, what was it, 6%? Really, wait a minute. So that means we're getting now from a rare 1 out of 100 to suddenly 1 out of 20. And we always have to remember it's not just that one person, right? It's all the affected individuals around that person. So if you're coming here the first time trying to get a grasp of what is the public health impact of gambling disorder on the community, it's vast in the sense that you have one person and then multiple others, and that the prevalence rates are fluctuating and growing and in the face of expansion. But even when we have more prevention and more treatment options, how much does that keep the prevalence rate down? That's where we don't really know, but we do know that simply more casinos, more access to gambling, less access for resorts, less access for prevention and treatment programs. Of course, you're going to have more problems down the road. I'll show this slide a lot about that range of gambling behavior. And it was interesting. I spoke to a group of undergrads this week, sociology students, who talked about this. And Dr. Richard Rosenthal, my mentor, friend, and colleague, said one of the first lessons he told me, although any of us can gamble compulsively, only a few can become compulsive gamblers. That was language he used back in the 90s. And it's still true where a vast majority of folks who do gamble recreationally do not incur harm. But just this past week, I developed a better saying, which is that you do not have to have a gambling problem to experience problems from gambling. So kind of this tautological, almost like a fortune cookie saying. But it makes sense, right? Because it means, imagine just one-time gambling creating a problem in your life. That doesn't make you, quote, gambling disorder, but it creates harm. So I think that was very, very important. A perfect example of that is a professional athlete who opens up a gambling app inside their training facility, and next thing you know, they're fined and suspended for their 6 games. They don't have a gambling disorder, but they had a significant problem caused by gambling. So, all right. DSM-5, for those of you how many of you are still students? One, two, anyone? Young people wearing the suits. I love that. And how many people are just out of school and within their first 2 years of clinical practice? So we have a few. Okay, that's great. Terrific. So you go back into school and you say, how much training did we get on gambling? Very little. But the perspective is this. DSM-5 views gambling disorder and places it in the chapter of substance-related and addictive disorder. It's an addiction. When I started in this field in 1999, it was not considered an addiction. It was considered a impulse control disorder, like pyromania, kleptomania, trichotillomania. So imagine that. Wow, we shifted from, we're not sure what really causes this, and it's in the same category as things that are kind of bizarre behaviors, and now we're park it where it belongs in the category of addiction. But then you think about what's happened in our field. We don't still get 100% funding from addiction services. Sometimes it's from mental health, sometimes it's from other areas in public health. So it's not really truly mapped up yet. But it's an addictive disorder. Same brain, same region, same areas affected by any other substance use disorder. I don't memorize criteria. It's so difficult, and get older, it's hard for me to remember things anyway. But I just remember this very simply. Similar criteria to substance use disorder. But the unique ones for gambling disorder, again, are going to be chasing losses, getting a financial bailout. And I think as we change over the years, that financial bailout isn't just borrowing from people, borrowing from online loans and sources. I think that's a tremendous area. That is a bailout. That is not just finding. That's a bailout. That meets that criteria. So if you think about, well, how do I go through these criteria? I think the strategy should always be to think about what is it like to have these criteria and how it interfere with your life. Oftentimes people say, well, how do you tell a difference between someone who, again, gambles recreationally and socially? Well, again, they have these criteria not just one time, but ongoing, repetitive, happens repeatedly. So that means that preoccupation isn't just, I'm constantly thinking about Vegas when I'm going to Vegas. It means when you're not in Vegas and thinking about gambling, it interferes. All these symptoms interfere with your functioning and your ability to get things done and live your life in a healthy way. So we get that. We get a sense of that. I think we also have to do a much better job of doing this, screening out bipolar and actively being in a manic episode while they're gambling. I've had a number of cases where it turns out they only gamble when they were in a hypomanic or manic state, and call them then gambling disorder, I think, would be a disservice because it's not really the same thing. It's bipolar disorder. This is a trickier one from DSM-5, and this was new in DSM-5, the idea of putting a mild, moderate, severe rating to one's addictive disorder. And DSM-5 came out in 2013, which meant it was written in 2010. So we're talking about 13 years, way, way long. And I had mixed feelings about this. On one hand, it's amazing to be able to document with better precision how patients go through the clinical course and how they might start off as severe and then a few years later they're down the line. But the problem when we actually do it in real life is different. So if I say to someone, you have a mild gambling disorder, inevitably it backfires. So I've either had them say, hey, oh, you think this is mild? Well, I'll show you what mild is. And they're angry. But you say, oh, mild, that's not that big of a deal, right? So that means I can go out and hit the tables and not have a problem. So it serves as a little bit of a disservice. Mild is not a good thing. That means you are suffering from 4 or 5 of these criteria that are creating damage to your life. So I tend to be a little quieter on that. The reason there were some severity markers is that the idea was at the time that insurance companies were going to pay differential rates based on severity of your illness, or they were going to say no. We were also going to have placement criteria for residential treatment based on severity. Now, none of that has kind of come to be. I put that up there as a reminder that that is what's in DSM-5, and we do need better precision down the road, but we're not quite there yet with that. So a few things about the clinical characteristics we've learned over the years. Yes, it's a disease of the young, but it's also a disease of the middle age and disease of the older adult. But this is one of our biggest problems that still remains. We know that roughly it's about 10 years in time that you had your first symptom until you actually get treatment. And even then, there's a bunch of years that pass from the time you start gambling to the time you actually start developing problems. Now, we know that that problem is telescoping, right, because of the online world and access to money, so it's much shorter and shorter. But again, this is a fundamental question of prevention and treatment, which is how do we get people to go to treatment sooner? In the last 30 years, we've constantly been trying to think about this. How do we increase treatment demand? How do we actually get people motivated to come in and talk about very stigmatizing behavior? So I don't have all the answers. I'm just highlighting this is still something we need to do. This is where the people have to tell us. So many folks tell us very clearly, well, I finally decided to go in treatment when everything was really, really severe, or when I was in a state of lethal emotional pain. That's so late. The problem is when we think about cancer, same thing. A lot of people don't go into treatment because they don't know that they have the signs or symptoms of that disease. So the early screening is where we're actually doing that. You think about mammograms now, how much that's changed. It's getting younger and younger and younger and more frequent, all the idea of early detection. So again, that's where I'd like to see maybe the next generation of researchers really look at how do we do early detection and then early interventions. Again, early intervention can be something as simple as going online and watching a couple of key podcasts or talking once or twice to a peer recovery specialist. That might be enough. Don't know. Biopsychosocial condition, biopsychosocial solution, biopsychosocial risk factors. And we've highlighted just a few of these. There's many, 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 many more. But I think about when you're starting off in treatment, the way I phrase it out as I'm talking to a client, I have buckets, and I'm just listening. Is this a biological risk factor? Is this psychological? Is this social? Where do we fit? Things that have changed, obviously, greatly on the biological side. We very much know this is a genetic condition, family condition. Asking about that at intake is super, super important. There are now, again, medications, particularly Parkinson's medications or certain antidepressants that have been associated with gambling disorder to screen that out. Head injuries is particularly a risk factor there as well. Dementia and cognitive factors as well, also concerning. On the psychological side, of course, we have the co-occurring disorders, but I've also highlighted through the years personality traits that we know if you're born with, you start to have as a young person that will probably lead you to gamble and enjoy the gambling experience. Of course, that's people who enjoy taking risks, people who are impulsive, they think and act without thinking about the consequences, people who have the psychological concept of loss aversion, where let's say you lose $1,000 and most of us, people who do not have gambling disorder will be like, oh, that hurts, I'm not doing it again. I'm averse to pain, I don't want that again. And then you don't do that for a long stretch of time. But what we're showing psychologically for folks, gambling disorder clients, their loss aversion tends to be very, very minimal. Spend $1,000, it hurts in the moment, the next day in some way we're almost recovered and said, I'm ready to go back and chase my losses and go get more. So in another way, it's almost like a different version of optimism, unfortunately just targeted in the wrong area. Not having those coping strategies, the healthy coping strategies, and something Dr. Rosenthal taught me early on is psychological need for spectacular success. I think about the generationally about that. It's so interesting. I'm Gen X. We just want to be left alone. We just want to do our own thing, self-reliance, and listen to 80s music and reminisce about how great things were. Then you have the millennials, right, who celebrate themselves for their talents. Like LeBron James, right, and take my talents to South Florida and look at me and look at the things that I can do, right? Then you have Gen Z, which is like, we want to change the world. We want to influence the world and go for a better place and have a better world. Those are all elements that are important for us to view as psychological minds. And of course, social risk factors have changed so much. Think back to one of my very, very first trip to Las Vegas in 1998 compared to now, and what is so different in terms of availability, types of gambling, the access, and all that's changed just in the last 10 years, of course, with the smartphone. And of course, the embedded nature, the normalization of gambling. So we're now in the generation alpha, right? Those young folks between 0 and 20, they are growing up in a world where gambling is not a vice, it's not a sin, it's not hidden. It is up front and center as a normal, expected part of their daily routine. Our youngest son's 14, and I talked to some of his friends about betting and gambling and sports, and it's fascinating to me how many of them watch football not because of love of football, but because of fantasy football, or how they're equating this quarterback is equal to X number of passing yards, not as a person. So again, they've normalized that connection between gambling and sports. All right, so biopsychosocial risk factors. So when you're doing intakes, then go back to, let me document what are the biopsychosocial harm? What are the biopsychosocial consequences of this person? So you're actually to read my notes and see that, and that's how I just phrase it out when I'm doing the assessments, and I'll just put that in a column, risk factor, harmful consequences. That gives me kind of an easy template to use moving forward when I do treatment to identify which bucket are we going to focus on today. The biological side, we've been doing a lot of work showing how much gambling disorder impacts the body. Impairments on sleep, impairments on thinking, neurocognitive abilities, stress hormone elevations leading to things like heart attacks, high blood pressure, peptic ulcer disease, using more substances to cope with the suffering from gambling, leading again to substance use disorder, damaging the body. Psychological consequences, of course, phenomenally deep emotional pain and misery and desperation. But for the young people, losing opportunities at the point where you are now stalled in your growth and development. And imagine what's happened with the COVID behind that, combined with the gambling disorder. We're talking about men and women, 23, 24 years old, that have lost 5-6 years of life development. That's a tremendous, tremendous loss. Of course, worsening mental health conditions. The social consequences we think about, I worry about the most. Obviously, the isolation and loneliness this far and away is probably the most difficult and hardest thing to bear. We're already in a nation of an epidemic of loneliness. You put this in, particularly with mobile gambling, there is no better recipe for gambling alone than on the phone. And of course, we have a myriad of financial and legal stuff. So here's some data from our sleep work we did about maybe 10 years ago, just highlighting again with inside the body of someone with gambling disorder compared to sleep, not just falling asleep, but having poor sleep quality. And fundamentally, that leads to the next day where you're fuzzier, you're not as sharp, your defense mechanisms are weakened, you can't do the work of recovery very well. So amazingly, just this past year, I realized something so simple. I'll say to folks, biological psychosocial treatments. One of our biological treatments for your gambling disorder is sleep. And people are like, that's it? That's all you got for me, Doc? Sleep? I'm like, yeah, because it really is fundamental. And it's amazing how many people want, no, I want the brand new medication. Give me something new out of your drawer you haven't done with anybody else. I'll say, yeah, but I look at your sleep patterns and they're terrible. And until you can get 7 to 8 hours of consistent sleep for a month, your brain is not going to heal. And just something as simple as that makes a huge difference. And again, we always want something fancy that works, but the sleep is super important. Data from our state program shows this a couple years ago that the average amount of expenditure for our folks coming in is about $20,000 on gambling in the last year. That's an enormous chunk. The average income in our California state residents is about $45,000 to $50,000. And again, how do people live off that in California? we're talking about, again, that's why there are other debts, credit card debts and other things, in addition to their gambling, is absolutely phenomenally much higher. And unfortunately, we documented what we've always known, and that's that the suicidal thinking and the lethal emotional pain of gambling is very much real. 20% of our folks entering our state program say that within the last week, I wish I were dead or I had thought about killing myself. Meaning, the next part of fundamentals for you as clinicians and prevention specialists is how well mapped out are your emergency safety plans? How difficult is it to get a psychiatric bed here in the state of Nevada? Is that hard, Wiley? Difficult? Is there a long wait? So you roll into our UCLA emergency room. Invariably, there's about 100 people in the emergency room every day, and there's usually about 8 or 9 waiting for a bed in a psychiatric hospital. So, meaning that it is incredibly difficult to access. But just because someone is in this pit of active suicidality does not mean they have to be in a confined and contained 24-hour setting. Meaning us as mental health providers, folks who are actively suicidal, can manage this kind of crisis without having them contained. So I would encourage everyone to go back and say, how can we strengthen our resources for suicidality that give people access to relief right away instead of just or flexibly sending them to the emergency. All right, so this is brand new stuff right here. Just kind of invented, just for the sake of inventing. When they asked me, I'm not a prevention specialist. Don't do a lot of prevention outreach, but I have worked with a number of providers and groups over the years, and came up with just some basic strategies that I, as a clinician, think need to be thought about for gambling disorder in 2021. And I started with just age group. This is the under 21 crowd. So obviously talking about educating about dealing with loss. I don't see this enough, where you don't see in the school talking about how you're going to lose, you're going to have bad things happen to you, you're going to be disappointed, you're going to be rejected, this is how you deal with it. Now, it's a weird thing to say, right? Because we say, shouldn't that be part of growing up? And we shouldn't be telling people to feel bad. No, I think the opposite. We should be highlighting that bad stuff's going to happen, like a pandemic out of your control. But wouldn't it be better if we gave them self-efficacy and self-skills early? That's part of prevention. Number two, years ago, one of the first prevention programs I saw in the early 2000s was like teaching young people the odds, teaching them math, and using math to really help understand risks and things like that. I still think there's value in that. We certainly don't do it. I didn't see that in our son's curriculum. Managing the peer and pop culture influence, and really early on, encouraging people to say what you see online isn't the truth. Why I say that is so much on the online space related to gambling is what? People winning large amounts. People picking, I am 80% correct on all my football picks. You can't go wrong, you just follow me, right? Here's my data sheet, and it creates this mythology that people know more, people have greater skill. Well, one of the things I follow online is this comedic thing, is this 4-year-old girl that picks college football teams, right? She comes down the stairs and she just taps the helmet. And people were tracking her accuracy of picks was as high as 80%. She's so good. Well, that's the sort of thing we want the young people to realize, no, this is just pure entertainment. That does not challenge what you're seeing all the time. We really have to make sure we temper the advertising impact. So again, we don't know that impact yet, but we kind of know what's going to happen when you have nothing but positive-based themed ads celebrating gambling with celebrities, creating a theme that if you don't gamble, you are going to miss out. If you're not part of this, party is gone, and you're being left behind. I really think that advertising, we really got to take it to task a little bit more to come up for the young people, make sure they don't see that. Young people aren't seeing the cannabis or the tobacco ads, right? So those are very, very tightly regulated, but they are certainly seeing gambling ads along with it. Okay. For the college-age folks, 18 to 24, number one, this theme, gambling is not a consistent way of making money. I've seen so many college young folks who say to me, no, I thought it was a way of making $50 to $200 a week and not have to go work in the campus bookstore. I say to them, well, why didn't you want to work in the campus bookstore? Oh, it's boring. It's beneath me. I'd rather do other things. So I think highlighting that is super important for the young people. Talking about, again, what happens if you take out an online payday loan. What happens if you go take out $1,000 loan with 20% interest? What does that do to your credit score? Why shouldn't you do that in the middle of the night at midnight? That sort of thing. I think number 3, the other area that this group is really, really missing is figuring out where else can they, again, park their dopamine, park their neurochemicals that's responsible for reward and intention and experience and things like that. Because again, this is the group that already lost a lot in high school. This is a group that may have been told, oh, don't go out because it might be scary, but that's where they need more dopamine. They need competition and things like that. Our son, he's our first year in college, played travel hockey for 8 years, tons of competition, right? Gets to college, isn't playing travel hockey anymore. So I say to him, where are you getting that competition now? Where are you getting that thrill of competing? I say, Dad, I'm playing all these new sports, these intramurals. He also started boxing, not fighting somebody else, but doing, boxing things. So he's finding new outlets, for his dopamine, as we say. And lastly, for those of you who work on campuses, really work to establish a gambling policy. We tried this a couple times with UCLA, and haven't gotten very far. We have alcohol policies, we have tobacco policies, we have substance use policies at UCLA. But when they said to them, why don't we have a gambling policy, particularly for folks who are under 21 who are caught gambling on campus, in a campus building, shouldn't there be repercussions? And again, most of the time they're like, no, it's just gambling. Why do we want to put that into place? We don't have a hospital policy for gambling either. So I've seen nurses gambling on their phones in the psychiatric hospital. That's a problem. And yet people aren't ready to say, we're ready to do that, to actually put it in writing. So it's still highlighting where gambling hasn't caught up, and we still have a lot of work to do. But the only way we do that is by actually having policies that are in writing. And for the adults, 21 to 65, before we get to the older adults, number 1, accessing credible information, this idea of if you're curious about gambling and how it's impacting your body, brain, and mind, then you should be getting that information from folks like Nevada Council, National Council. You shouldn't be getting it from various other parts of the internet that who knows where it's actually coming. I also think the enticement area is a really critical part of what we all need to look at for prevention. Enticements, again, we've seen so many oftentimes where our patients sign up, get the enticements, they go into treatment, they try and stop those mailings from coming, and what happens? Mailings keep on coming. So we know we have to do better prevention work to minimize that. And maybe even potentially regulate. If I say to you, should we allow risk-free, sweat-free bets where you get $1,000 in virtual online betting money? That's a lot of money. That's a lot of credit, right? And I don't see other industries giving out that much. I don't see the cannabis industry giving out $500 worth of free cannabis right away. So we're talking about very large enticements that we really have to think about whether that should be regulated or reduced. Gambling screening, we'll talk about in a sec. And Dr. Nauer out of Rutgers has a whole idea of money-limiting strategies right away from folks who are beginning to start, when the time they start up with gambling, really having a fixed amount that they can spend until they learn and get their feet under them in terms of their gambling experience. For older adults, number 1, I'm talking about this for many, many years. I just don't see us doing it enough. Getting on those casino buses and really having discussions with folks on the buses. Not to tell them to not go, to educate and understand how gambling is impacting their lives. When I was in Chicago a couple weeks ago and we were doing a conference on Asian American problem gambling, looked at the bus schedule that went from Chinatown, Chicago, to the casino every hour on the hour. 12 buses a day. When I talked to the folks, how many people are on that bus? 50 to 60 every bus. We're talking about hundreds of people constantly riding every day to and from. And to me, and the vast majority of them are older adults. That is a perfect prevention program I'd like us to look at. And then for the older adults, loneliness. And unfortunately, we see gambling turn as a solution for loneliness, and whether it's marketed through an assisted living or a senior center doing that. I think we really need to reverse that, because I have so many older adults that say to me, I wish I had something other than this. I say, what do you mean? Or I'm so lonely, I wish I had someone to talk with. The only place I have someone to talk with is in the casino. And I think that's a statement in our society that we reach that point where that's the only place that people talk. I think we can do a lot better. All right. So for the screening principles, number one, I really want to highlight a couple of things. Open-ended. Tell me about your gambling behavior. Tell me how you spend your money. Tell me how you view this gambling. What do you think about all these ads about sports betting? What are your views about the casino growth? How do you feel about what's happened to America as a country? So just open discussions like that. And then you can start drilling down. The one we use and recommend if you're not a gambling treatment program is the short, brief biosocial gambling screen. 3 items. Yes item then means I should do a thicker and longer interview. It does not mean you have a gambling disorder. So that's the one we use. There's 300, many others there you can use. I like that one. But here's the problem with screening, right? When do you do it? How do you do it? How often should you do it? And again, how many of those positive screening actually translate into referrals and appointments? And unfortunately, that's where we know you do a lot of screening, and even if you set up referral systems, if they don't come, they just don't come. Right? So, but then we thought, well, maybe just the screening in of itself is probably enough to get some folks thinking about their behavior, getting them to rethink, well, maybe I should not be doing this as much. We were doing a project with a tribal American Indian health clinic out in Riverside County, and they've been doing the screening for about 2 years, and we're getting, 1% of folks screening positive. They then get an immediate brief interview with a trained counselor. Screen positive for gambling. Let's talk about that a little bit. Oftentimes, that's a 2-minute intervention, maybe 10 minutes. And then they always say, would you like to meet with a therapist and talk more? How many do you think referrals we've gotten? We've gotten 2. So the systems are in place. The people these are folks coming into our primary health care clinic. They're going in for a health checkup. They're not expected to come out with a gambling disorder. So that's been a perfect example where we screen, and we think just the power of screening and that brief conversation is enough to get people at least starting to think about it. It's not translating into referrals. Okay. All right, so getting into the treatment side of things, biopsychosocial treatments. So the biological treatments, obviously medications, and I have a whole other slide, I'll get into that, we'll go to that in a sec. Psychological treatments, various individual therapies that we provide, and of course the social treatments, Gamblers Anonymous, and some of our other newer technological issues. And here's where we are with medications. Unfortunately, we don't have FDA-approved medication. I do not believe we will get one in the next 10 years. It's just not something pharmaceutical companies are willing to invest $150 million in. Right? But there may be, but that doesn't mean medications don't have a role for helping folks here. And obviously they help treat the co-occurring disorder, ADHD, depression, bipolar, whatever else is there that's making gambling worse. Number 2, we do have some medications for the year that do reduce the craving, reduce the preoccupation, reduce gambling behavior, but not get it all the way to 0. Too often, patients say to me, oh, hey, I took this medication you gave me. 6 weeks later, I'm gambling half as much as I did before in terms of frequency and time, but I'm not at 0, so I'm failing. I'll say, no, it's actually reducing it, and that's part of the expectation for folks to recognize. This is my menu for biological treatments. Again, I mentioned sleep. I'll say it to patients very, very clearly. Our biological treatments to help heal your brain, and you're going to focus on sleep. You're going to focus on sleep hygiene, and this can take a lot of time. Sometimes people have very poor sleep hygiene, caffeine and staying up late and watching the screens. And my basic tool I'll emphasize before I go to sleep medications are behavioral treatments, weighted blankets, and melatonin as an over-the-counter idea. But just empowering people to take charge of their sleep. And too often people minimize it. They're like, oh, it's not important. I'm super busy. It's not that big of a deal. I'm built differently. I don't need a lot of sleep, right? So we've kind of stigmatized getting sleep. And I think back again, you think back to the young people in college, they said, oh, I'm not going to go out. I'm going to come home early and go to bed early, right? Oh, come on. Why would you do that? You can sleep when you're dead. Let's just party. We minimize sleep's value. This is maximizing because just every night we need that to refresh our brain. Physical movement is a biological treatment. So I had a case of this when it came out of a guy with ADHD and gambling disorder, and he wanted to work out more, but his wife wouldn't let him. And I looked at the wife and said, do you realize physical movement is a treatment for his ADHD? She said, what do you mean? She's like, this helps stabilize the brain, stabilize hormones, and all these things. And she's like, oh, I thought he was just using that as an excuse to not be around the kids. So physical movement, super critical. Now there's been talk that even as little as 4,000 steps a day, 45 minutes movement per day is more than enough to get the maximum health benefits of exercise. That's a whole talk in itself. Nutrition, again, is a biological treatment. Food is medicine. Now, in medical school, we get very, very little training. But now we're seeing time and again studies showing that highly processed food, ultra-processed food, leads to what? Chronic states of inflammation, difficulties in releasing of stress hormone. Those are all biological inputs and challenges. So you rework yourself. And for those of you in recovery, think about your own experience, and I'm guaranteed this is probably what happened too. That over time, as your recovery strengthened, your ability to eat healthier probably also strengthened. Or it may have switched from gambling or alcohol into eating these highly processed foods. So that's a certain important aspect. And lastly, we have some other newer things on pipeline, including things like transcranial magnetic stimulation and other very interesting medications that we're thinking about. For the psychological treatments, and again, what I've learned through the years, unfortunately, at least in my perspective, I don't see one form of psychotherapy as head and shoulders better than everything else. But I do think we owe it to patients and clients to explain to them, this is the type of psychotherapy I'm providing, this is how long we're going to do it, and these are the potential side effects and the potential expectations. That's, for me, coming from a medical perspective, I think that's very important. Because what we have learned that what will predict good outcomes is the more time and more investment they do, they come back, they do. There's a capacity for honesty for them to actually tell you what truly is going on, how much gambling they've actually done. We know that that's likely to have a better outcome. And a commitment to doing the work. The kind of work I do, you can tell, is very practically based, very task-oriented, very much saying the work isn't done in this office with me. The work is done out in the real world, and here are the 4 or 5 things I want you to do. I'm going to make sure you do them, and we'll come back and talk about that later. I also think having others involved, oftentimes with the Zoom, how many of you do this with the Zoom, where you'll have a client and a couple other windows open with their wife or their husband or the kids? It makes for a really unusual experience, right? But it also allows us to bring more people in. So I'm a big proponent of doing family sessions again. Under the social treatments, of course, we have self-exclusion. Self-exclusion, though, from gambling apps, mobile apps, deals with it differently, right? It's called just deleting it. But at the same time, there are other things that we can think about. Gamblers Anonymous, of course, has spread and continue to thrive in the online world and the in-person world. And I've always found myself saying to folks, definitely try out different meetings, but definitely do 2 things. Seek out a sponsor, and have a commitment to the meetings. So in real life meetings, setting up the chair, getting coffee, passing the books out. I don't know what a commitment looks like in an online meeting, so maybe someone can tell me what that looks like. Maybe that's setting up a Zoom or something, but definitely having a commitment to doing something for the meeting. Smart recovery is a nice alternative option for him. So a couple other treatment principles to keep in mind as I think about it. I don't like to call it relapse anymore. We've kind of gotten away from that. A little bit of a pejorative term. We kind of emphasize it that it just kind of happened when in fact that's not true. Reoccurrence of gambling behaviors, both inside and of course during recovery, is what I like it. I like to continue to define the recovery goals of what the client wants, what they seek. Treat the co-occurring disorders and the ones we miss so often, ADHD, nicotine, we just tend to dismiss it or not think about it, and of course really emphasizing the shame and stigma that these folks have at every single step. How hard is it? How many times do I have patients saying, I was afraid to tell you that I gambled from the last session? And I'll say, if you can't tell me, you can't tell anyone else, that's a concern. What is it about me that makes it so hard? I don't judge you, I don't laugh at you, I don't criticize you, I don't berate you. So what is it? And oftentimes it's just, I just want to do well, and it's hard. All right, so new resources. This is an oldie but goodie that we wrote about 10 years ago, where we are trying to again update this. This is a self-help workbook available on our website, 25, 30-page PDF, and give to clients and toss it out in the email. They can read it at their own leisure. They can do various exercises, stimulating their mind and brain and thinking about what life would look like without gambling or reduced gambling. available on our website. I have 4 new ones here. Jeff, where are you, Jeff? I know you're here somewhere. Sam, you in the room yet? Is he coming? He's not coming? So up there in the corner is Evi and Jeff Murata and Sam Demel. And I just learned about this a couple months ago. It is a very, very well-produced gambling recovery app. All I'm going to say, you're going to do a presentation on that later. I really like the work that they have there available for folks. Number 2, on the right, of course, Gamban. How many of you have used Gamban with your clients? Not many. Just a couple. Yeah, pretty thumbs up? Yeah. So it's a tool. It's a software blocker that prevents the client from going on their website, their phone, or anything else to access their gambling websites, regulated or unregulated, which is really important. So it's not going to stop everything, but it's a tool and a device. So I found that shutting off the internet is not an effective tool. So that's certainly part of it. Kindbridge is a national telehealth company that does gambling and gaming disorder treatment via telehealth. That's another option there. They do take some insurances. That's an interesting option there as well. And Gamfin. Are the folks from Gamfin here? Usually they make the circuit out there. So Gamfin is a new company, about maybe 2-3 years old, that it's really financial counselors themselves. So it's not gambling counselors, it's financial counselors. We talk about very, very explicit detail how to repair some of the damage, how to deal with the financial thing. I get a lot of patients who misunderstand financial debt, right? And they're like, oh my God, I got to pay all these debts off. If I don't, they're going to come after me and end up in debtor's prison. Debtor's prison. I mean, does anyone know where the debtor's prison is? I'd like to visit it because I've had now at least 4 clients tell me they're worried about going to debtor's prison. I'm like, that sounds very Dickensian. Don't think we have these in America anymore. But it's just this myth that people have that if your finances are screwed up or that you owe credit card or surreptitiously predatory online lenders, you owe them, somehow going to come after you. That's a concern, and particularly the online lenders are really struggling. All right. Our state of California, we've had a state-funded program since 2009 called CalGets. You can take a look at the website there. And if anyone that you meet who's in Nevada and they're moving to California, or they're from California and they're living in Nevada, but they still have a California residence, they could actually receive care as a California resident in Nevada. Does that make sense? So meaning, as long as they're a California resident, they live here, we can provide no-cost services to them. And I know there's lots of folks who here in Nevada that are from California. I've always wanted to get a Nevada local resident card, so if anyone can help me out with that, that would be amazing. We get those golf courses for significantly reduced price. So, but we have a state program. We have it all. We have a residential program, intensive outpatient. We have a enhanced outpatient specifically for sports betting. We have 150 licensed providers. We have telephone services. We have it all. We're very proud of what we built, but we still have areas to innovate. We still have areas that we can do better at. So think about that. All right, so let's turn to the Q&A portion. I think that gives us about 15 minutes of that, which is really great. Here's a couple of things here. My cell phone is right there. That's my UCLA cell phone. You can text me. You can email me questions. If you ever want additional clinical guidance and supervision, we can do that for you. We have folks that can do that. That QR code, I'm very proud of that. Hopefully that works. That pops my contact into your phone. Now, it took me like an hour to figure that out, and then our 18-year-old son said, Dad, did you know that you can go into LinkedIn search bar and you can do right-click and it'll generate a QR code? I'm like, what? And I did that, and it literally like 3 seconds. So that's the big tip for today. LinkedIn search bar, click it, and you get the QR code generation. That was pretty cool. So thank you, Wiley, for inviting me. I know Carol's not here, but she's at home, and we got to give an acknowledgement to Carol. She was one of the very first people I met in the gambling field back in 1999, and she holds a special place in my heart for sure. And thank you for everyone for your attention. Use the mic. Tell us who you are. We'll fire off some questions, and we'll get started with the rest of the conference.